seeing Medi-Cal cut. We hit meaningful scale revenues, and now it's massive steps backwards. And I'm supposed to make sense of this year and make investments. How would you describe this year, hearing all of that? Because sometimes lowering tides actually reward the best operators.
Our company historically grew 20, 30,000 members in every annual enrollment period. This last annual enrollment period, we grew 127,000 members. So I can tell you, we feel very strongly that our growth was good growth. I can tell you that many of the other Medicare Advantage operators who grew this last year are pooping their pants, to use a technical term, Roy, because they now have to manage large numbers of members across vast geographies where they don't necessarily have a lot of the levers that they need to have to control total cost of care.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
And increases top line revenues from 2.7 billion to 8 billion. And you mentioned the membership climbs to 440,000.
Look, we've had an incredible run the last 5 years.
My question is, so my question, how much of that growth is geographic? You know, you found New Mexico, Texas, and wow, Texas is incredible. I'm so glad I entered that state. How much of that growth is vertical integration? You know, I was doing reimbursement, now I'm doing reimbursement plus provision of care, acquisition. How much of it is a function of your roots as a business? Hey, we came out of Southern Cal, and we're about to come out in the next few days with the top 50. That's the wrong headline. Let's fix the headline. With the evaluation of who are the top states for healthcare within the country. And actually, California is going to score very highly, which will shock a few people because of headline bias, right? There's this thing called headline bias where a chunk of our brain thinks of reality based on headlines that we've been offered, not based on the real science or the empirical information, just the headlines. So California always garners interesting healthcare headlines. Oscar left California, right? An example. For better or for worse. So how much of all that growth is the states, your roots, or your vertical integration?
I would say most of the growth is California. We have had significant growth in Arizona, Nevada, New Mexico, Texas, Washington State. You know, New Mexico, we still struggle with membership, candidly. But what I would say is that we have an almost 50-year history now of delivering care and service in California. I would say the big shift in California is that most of our membership was in Southern California previously. Today, you can say we're truly an all California plan. So we have a large number of members now in Northern California. And I would say the drivers of the growth have been a few things. One is we've had consistently high star ratings, which translates into higher revenue for the plan because star ratings are associated with star bonuses. And we pay most of our providers on a percentage of premium. So if you get a higher revenue number from the federal government, you're going to pass on more revenue to providers. And so in this environment of increasingly constrained payments to providers, a health plan that is consistently 4+ stars, as we have been for more than 12 years now in California, is going to consistently pay you more than other health plans. So I think many provider groups are now making the rational choice to narrow the field of health plans that they partner with and partner with only higher star rated plans so that they can benefit from the higher star ratings and the higher star revenues.
And that transition into controlling the end distribution point, the providers. Those providers are mostly in California as well, or they're sprinkled across those states too?
Primarily, we've got large risk-bearing provider groups that we partner with. SCAN is different from a lot of Medicare Advantage plans in that about 90% of our members sit in groups to whom we fully delegate the risk. So we are experts in risk delegation. So many of the criticisms of Medicare Advantage, there's too much utilization management. Well, we don't do very much utilization management because it's actually our provider groups that own the risk, and they are making the choice themselves around what they'd like to.
So these are provider groups that are happy to take on risk. We can manage costs.
Exactly. A percentage of premium, so to speak.
We can map you step for step on the analytics. We'll adjust our own behavior. Give it to us. We want to be grown-ups.
You got it. You got it. You got it. So lots of entities talk about value-based care. Our partners really do it, and they've been doing it for decades at this point.
So if you partner with, I don't know, 1,000 clinicians, 10,000, whatever the number is, 100,000 clinicians, how many of that pie, what percentage do you now control as an owner?
Oh, we don't own, we own very little. We probably employ less than 100 physicians. I mean,
really?
Yes, across all of our groups. We have Welcome Health, Home-Based Medical, Healthcare in Action, which is our street medicine group, and My Place Health, which is our PACE entity, and Embrace, which is our institutional special needs plan that has its own primary care group associated with it.
So Healthcare in Action, Welcome Health, Home-Based, My Place. Okay, so the acquisition of residential and My Place. So all of that combined is just a few hundred physicians?
Less than 100, physicians, and probably less than 200 APPs and physicians altogether.
Okay, so it's a tiny percentage of your...
Small. We're planning for the next 50 years, right? I think owning some delivery of care, we believe, is really important in the future for a variety of strategic reasons. But we're not in any rush to get to scale on that. We're just right now, building this block by block, one at a time.
Okay, so it's nice and steady. Slow, controlled pace on the provision of care. Someone should have told Walgreens that.
May have told Walgreens that. I don't want to. I did. I had many conversations with the Walgreens team.
Yeah, they didn't listen.
Absolutely.
They did not listen. Okay, so it sounds like owning these entities is very instructive, very educational, but not necessarily more than that at this point.
That's right. That's right.
It's not foundational. It's not core yet. Okay, so California, Northern California. I spoke very recently with David Joyner, the CEO of the Health.
Love David Joyner. Yeah.
He's
Great.
Incredibly highly reviewed. He described this year using Queen Elizabeth's term annus horribilis.
I don't know that term.
That's how she described it. I can't remember what year, but that was the year that Windsor Castle burnt down. She lost a lot of her art. That was a bad year. Many other things happened I'm not even going to bring up because they're so painful to a former Brit. Annus horribilis. So he said, look, we're seeing Medicare Advantage cuts. We're seeing Medi-Cal cut. We're seeing whatever we have in ACA cut. And so we hit, I'm not going to name it, but we hit meaningful scale revenues. And now it's massive steps backwards. And I'm supposed to make sense of this year and make investments. How would you describe this year hearing all of that? Because sometimes lowering tides actually reward the best operators.
That's kind of how it played out for us, candidly, Roy. I mean, our company historically grew 20, 30,000 members in every annual enrollment period. This last annual enrollment period, we grew 127,000 members. So
my thesis might have some merit here, that it's not necessarily a disaster. You need to look at the year in retrospect, the end of the year, to really know for sure. Just because it's a difficult environment doesn't mean a good operator can't outperform. Tell me about some.
I also think you don't know if something is, if growth is good growth for a few years. Yeah. I mean, I can tell you, we feel very strongly that our growth was good growth. I can tell you that many of the other Medicare Advantage operators who grew this last year are pooping their pants, to use a technical term, Roy, because they now have to manage large numbers of members across vast geographies where they don't necessarily have a lot of the levers that they need to have to control total cost of care.
Or even provide service. This is another theme that I've studied, seen examples of recently, of networks that are not really as available or built out or even real as the given payer represents that they are. And eventually those pigeons come home to roost.
Always do. They always do. They always do. And you saw that, right? Many plans offered rich benefits a few years ago. They oversold. The cost of care went through the roof. They then exited markets. They cut benefits. Other plans picked up that membership. So there's a little bit of a game of hot potato that's being played right now. And so I think we're just navigating all those headwinds.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.